This podcast is produced by the Center for Deployment Psychology at the Uniformed Services University of the Health Sciences. The views expressed are those of the speakers and do not necessarily reflect the opinions of the Uniformed Services University, the Department of Defense, or the U.S. government. In addition, references to any specific companies, products, processes, or services does not necessarily constitute or imply endorsement by the Uniformed Services University, the Department of Defense, or the U.S. government. Welcome to CDP's podcast, Practical for Your Practice,
where we give you actionable intel to support what you do.
One colleague to another. I'm Jenna Ermold, Assistant Director of Training and Education, and joined by podcast co-conspirator Dr. Kevin Holloway, Director of Training and Education. Hey, Kevin.
How are you?
And today we are delighted to welcome Dr. Kelly Chrestman, who is by far one of CDP's top PE mavens extraordinaire. 20 plus years in the field of working with prolonged exposure. Kelly is a fantastic instructor and also one of our PE consultants. So Kelly, welcome to Practical for Your Practice. We're so glad you're here.
Thanks for inviting me. It's fun to be here.
So today we thought we would have a conversation with you about some things that we're noticing in consultation. So CDP does consultation for prolonged exposure, both just kind of a general consultation group, and we consult with specific military installations. And Kevin, Kelly, and I are all a part of that. And one of the things that's been striking to us is all the amazing work that providers are doing to try and work with their, especially in vivo work with clients amidst this pandemic. So, we have a pandemic, we have stay-at-home orders in place at times, and providers are having to really evaluate and think about what is safe. When we do an in vivo hierarchy, one of the things we have to determine is how relative risk and how safe an item is, right? COVID and the pandemic has kind of changed that game a little bit for providers. So we thought we'd talk today about what are some of the things we're seeing when we're hearing when we do consultation, and share maybe some of the strategies we've helped some providers employ around that. So I guess, Kelly, if you can kick us off, and in general, what are some of the concerns we're seeing and some of the questions we're answering?
Well, in the beginning of the pandemic, I think people were super concerned because they were thinking, I think in our imaginations, we think every in vivo exposure has to do with going out into a crowd, because crowds end up on almost every in vivo exposure list, regardless of what the trauma is. And so I think people were focusing on, oh my gosh, I can't send my clients out into a crowd during this pandemic because they'll get sick. And they were forgetting that there were so many other things on the in vivo exposure that they could work on. So that was one thing. And I think since the beginning of the pandemic, we've kind of settled down about that. And we've figured out, there are some instances where we can do some crowd exposures. There are people we probably won't ever send out into a crowd. For example, if somebody's immune compromised or they just had chemotherapy. But by and large, if people are wearing their masks and using their hand sanitizers and observing social distancing, then we can send them into crowds. I would say, though, all of those precautions we take change the nature of the exposure.
Well, I was going to ask you a question about that, Kelly. So,
yeah.
we think about that too. I think that's where I was at the beginning of the pandemic as well, as worrying about sending people out into the world that we had all been told not to go out into, right? And thinking about just the actual real danger about those situations, that they're different because of the pandemic than they would be otherwise. But then, like you said, we've settled down and we can think about ways that in general people can safely at least be out of their houses, right? And limiting crowds and social distancing and such. But like you just said, it kind of changes the nature of the exposure for some people, right? Like if you've got a client that you want to send to a big box store, most of the time we can think about, okay, well, you can probably be there and you wear your mask and you use the hand sanitizer. And for some people that's fine because the thing that they're avoiding at a place like a big box store may have nothing to do with whether their face is visible or whether they have to touch things, right? And I'm thinking things that are kind of overlapping, maybe a little more with OCD things too. But what about for those people that, that person that was worried about if they go out in public among other people that they're going to get overwhelmed and then they're going to fall apart and they're going to look really embarrassed or they're going to do something really crazy. And that mask changes it because it gives them some anonymity or it hides their facial expressions or their natural reactions.
That's right. And you won't know that if you don't ask the patient. And you won't know that if you don't identify with the patient what their worst, consequence would be. So when we send people out to do exposures, regardless of the pandemic, we say to them before they go, we kind of remind them, okay, this item on your exposure hierarchy, when you do this, when you think about doing this right now, what do you worry about will happen? And so they tell us, and if somehow the mask changes whether they worry about that or not. Like I know I've had a patient who worried about being recognized. And gosh, this is a gift. Being able to wear a mask everywhere is like the best avoidance ever because they can hide behind a mask. Exactly. And so, so you want to think about those things and you might not, if you don't ask those questions, you won't get those answers. So I think it's in all times, not just during the pandemic, we need to ask our patients, what are you worried about will happen? And how can we do exposure in a way that will show you this isn't a realistic fear? This isn't something that you need to be worried about in that situation. So I would ask about the mask. I would ask about, what it is they worry about if they wear it versus when they don't wear it. Their SUDS may change. For example, if they wear the mask, they may be less or more anxious than if they don't. So that's an important thing to think about. Crowds aren't the only thing, though, and I think for a lot of people, crowds sort of gets magnified because there are other people involved and they have to go out into an unknown place. But there are lots of things on people's in vivo hierarchies that have nothing to do with contact with other people. And so starting with a lot of those things can be really helpful, not just to not have to go out into crowds, but also to give people kind of training in how to do in vivo exposure. So starting with things that are less complicated. The other thing I would say about crowds is whether it's a pandemic or not, crowds often include multiple stimuli. So, it's not just being around other people. It's what might happen when other people are around. It's different kinds of people, which may have different levels of anxiety associated with them. So, for example, men and women or big people, small people, people of different races or who speak different languages, people who are, who represent in some way a trigger. More
crowds have
more
smells
so than
too.
others.
Perfume, cologne.
Yes, actually, smells, sounds, places that
Kids
the crowd
screaming.
could be.
Right.
Kids screaming. And so one of the rules of thumb when you do exposure is you really want to do exposure to one stimuli at a time. When you do crowd exposure, there's no way you can just do exposure to one stimuli at a time. And so you really want to think about what other stimuli might be present. And to me, that makes crowds higher on the list. That even if someone is rating them relatively low, I would look to see if there are other things that might happen during the crowd that might be on some of their other items. And then make that decision accordingly.
Sorry, I was going to say.
Go ahead.
We're so eager to talk to you, Kelly. So you're kind of mentioning, you're alluding to this idea that it's not just about crowds, right. And we've got lots of other things on the list. One of the things I found interesting, and listening to you consult sometimes, Kelly, is how do we help people leverage technology? How do we, if we can't send them out to crowds or that's not where they are yet and they've got these other items, what kind of creative things have you seen folks doing or have you suggested in leveraging some technology?
Well, the internet has been the biggest gift to exposure therapy that ever was. I mean, if there's something that makes someone anxious, you can find a video about it, or you can find a sound recording, or you can find an image online that that'll be pretty close to what they worry about. And that often is a good entry-level exposure for someone who's worried about particular things happening. So, for example, if somebody's worried about crowds, they may be worried about people getting close to them and bumping into them and maybe being dangerous. So watching a video about someone they can identify with walking through a crowd and getting bumped into may make their anxiety rise a little bit. And so that might be a good first video
I like that
before
you're
they
saying,
go out and do crowds.
I like what you're saying first, though, because there's a part of me that's like, I can hear some of the folks I've consulted with saying, well, a video is not the same as doing it.
It's not.
Right?
No, it's certainly not.
Or seeing it on the internet or hearing the sound recording. It's a little bit of a different experience because they can convince themselves that this isn't happening to them right now. But it sounds to me like what you're suggesting is this is a good like bridge step, right? That from not doing it at all to doing it and having this bridge step to help them to get engaged and get off of inertia and to start to feel and access those feelings that come with that exposure.
I just got a consultation from someone yesterday who had sent someone out to do driving exposure. So they were driving and they had been in a motor vehicle accident. So this was a big exposure for them. And the therapist had started them out doing driving, and it was the suds of a 70. And the person threw up because they got so anxious. And they hadn't had that symptom in the past. So they throwing up hadn't been part of that is part of some people's anxiety, but it wasn't for this client that she habitually would throw up when she was anxious. But she threw up. And so the therapist wanted to stop PE and do a bunch of relaxation training and calming exercises. And so we talked about that. And that I told them not to do that, right?
I was going to say, did the PE police show up at the door at that point?
So for them, the most obvious piece of consultation, helpful advice I could have given that situation is, let's not start at a 70. And so, sending someone out to drive in a situation, driving is like crowds, right? Especially if it's a motor vehicle accident. How many different stimuli make you worry about accidents if you've had a motor vehicle accident? Even if you've had a little fender bender and you get back into the car again, there are all kinds of things you now watch differently and you do differently and more carefully as you sort of get used to driving again after an accident. And so, we want to start lower. And so the therapist was reluctant to have the patient sit in their car and drive around the block in their neighborhood because that didn't get them really uncomfortable, but it did make their anxiety rise. And it was, it was something at about a 40. And that's where I would have wanted them to start. And so I want to say about those untoward reactions that happen in exposure, throwing up, for example, or having a panic attack would be another one. We want to avoid stuff like that. We don't want our patients to experience anxiety that's so overwhelming that they have a panic attack or throw up. Now, if they do, it's not the end of the world, and we can help them with that. But what we run the risk of doing when we allow that to happen, when we assign things that are too high and we send people out, and they have that kind of reaction, is we also set up a new association with the stimuli, which is now it's associated with throwing up, which is really uncomfortable. So
especially in your car.
Yeah, they were leather seats.
So now the person not only is worried about having an accident, but they also are worried about throwing up. So now they have two things associated with driving that they get triggered and worry about. And so you can see how that would even become potentially a phobia.
And that specific one sounds like a great one too, where you've got technology, you've got screeching tires, you've got driving, simulated driving, all sorts of options there. So
absolutely. I don't know if you all can remember the blog that we put out in the beginning of the pandemic, when we looked at our good old training tools that we have, and we have in our training packet, we have 4 examples of in vivo exposure items that might be paired with a particular type of trauma, not because everyone is avoiding these things if you have that trauma, but because it's just helpful for new therapists to have a place to start, to see what kinds of items might go on a hierarchy. So for, motor vehicle accidents, we have, wearing a seatbelt or not wearing a seatbelt, or checking traffic, or, avoiding certain roads, things like that. And so you can ask your client about it. So we went back just as an exercise to see when the pandemic began, which of these items could actually be done regardless of the pandemic. And more than half of them were unchanged. They were things like, watching a video about this, or smell or a sound, or, different things that the pandemic wouldn't have changed at all. And then there were many, many others that could be confronted via technology, like you were saying. So, videos and sound clips of screeching tires and things like that. So it wasn't that the pandemic limited the people greatly in what they could do, but it sort of challenged their creativity to figure out how to do things differently if they were in that situation.
Flex new muscles.
Yeah, flex new muscle.
Which outside of the pandemic is still a good muscle to flex. I mean, it's a good skill to develop anyway, is to think about creativity and how do we do these differently.
Yeah.
So one question I had for you, and this really speaks to what you were just talking about, that there are a number of things that we might commonly hear or that might commonly appear on a hierarchy that are unchanged. We have some that require a little bit of adjustment, and there may be some that we just don't do because of the pandemic or because of whatever the circumstances are, that those things are truly dangerous, whereas in other circumstances they wouldn't be. But I guess that, and it speaks to earlier you said that there are some things we can start with, things that are going to be lower on the list, or that we can simplify and focus on one stimuli at a time. And, maybe we can put off some of those others. But one question that I keep getting as well is, that this pandemic has certainly lasted longer than anybody initially thought. So putting things off, therapy was ending before the pandemic ended, it's just putting things off indefinitely. Maybe that was an issue. There are a lot of therapists I've worked with that worry that if we don't hit everything on the hierarchy in some way, then therapy is still destined to not be effective, right? That if we have to put stuff off, or if crowds really is the thing and wearing the mask changes it so that it's not as effective, wow, that's not going to be an effective therapy. Can you speak to the idea of, do we have to hit everything on that list?
Well, I mean, I'm a completer. I like to hit everything on the list.
Sure.
But you can't. And I've had many cases where I didn't hit everything on the list for lots of reasons other than the pandemic. And I think there's a few things to think about when you have a client and there are things that you can't get to on that list. Number one is that we have this wonderful behavioral principle of generalization that occurs. So the more things you hit, the less anxiety provoking all of the items become, because the patient not only is learning specific information about situations that they actually go into in their in vivo exposures, but they're learning how their anxiety works.
Right.
And so they're learning that, yes, even if I do this and I feel anxious, my anxiety can begin to dissipate and I can confront these situations without flying apart or losing it somehow or getting harmed. And so they begin to have more courage to even take on things that they didn't have previously. And so that begins to change even if we don't confront every situation. I think that there are some patients who may worry that if they don't do something on their list, that they somehow didn't complete therapy or they'll somehow never be able to do it. Or if they're one of those patients that hasn't quite made the progress you want and they're still somewhat symptomatic and you're coming toward the end of treatment. And one of the things you could try to do, and this is off protocol, this is not part of the PE protocol, but it's not inconsistent with PE, and that is you could do imaginal exposure with the in vivo situation. Yeah. So you could have the person close their eyes, have them walk, and in this case, I would help them develop a script. And so this would be a little bit different than, I don't know that I would do it like a complete OCD imaginal exposure where we have these outlandish outcomes that people worry about, but I would have them imagine some of the negative outcomes that could happen in that situation and walk their way through it and kind of look at it. But, this is something you could try with a patient and monitor SUDS and use the data that you get to see if it's impacting their level of anxiety. So that's one thing that you could try. But I wouldn't worry about completion as much as you can also look and see if there are other things on the hierarchy that are similar. Make sure that they've done those things.
I think that's something that we've talked about before that was really useful as well, right? That even if the specific item on the list either can't be done or there's some constraint that gets in the way, what you talked about earlier, asking the client what it is, this terrible outcome that they would anticipate, or what is it that they're actually avoiding about that situation. Perhaps we can come up with alternative situations that are still getting at that same concern, that same worry, that same anticipated bad outcome, that are accessible. Still
agreed.
work on that same thing. And this may not even be really relevant to today, but at the start of the pandemic, there were a lot of therapists that we consulted with that were unsure if PE could even be done at all in a telehealth kind of context, because we all found ourselves, all of a sudden clinics were being shut down, and people were in the middle of therapy or just starting therapy, and didn't feel safe coming into clinics that were open, or just didn't even have that option. And we were all suddenly found ourselves doing therapy online. And there was lots of worries about, can PE even be done this way? If I can only see people from the shoulders up, am I getting enough information about how this is landing on them?
Or via telephone.
Or on the telephone, absolutely.
I work with,
or even just the idea, like recordings not working right, like we would if we were face to face, like all that kind of stuff. I think everybody that's been doing this has learned that yes, you can. Of course, you can do PE via telehealth.
Sure. Yeah.
But are there any kind of themes that have come up about ideas that people could use on how to make that transition easier if they haven't already been forced to do it, to do like PE or other ABPs via telehealth?
I was just going to say quickly, one thing that I think is important is having a conversation about what, the practical stuff. Where are you doing this? You're having trouble sleeping. Let's not sit on the bed and do imaginal. How do you build in some time before to get your head on? How do you build in some time after before you open the door to 3 children? So there's just some practical things. I think if you stop before you start with your client and say, let's set this up to make it most successful for you. Where they're not going to be interrupted. I mean, we've had people do some really different stuff and it's been okay. I mean, I think that's the other thing, the robustness. Yes. The only place this person can do it is on their front porch, and it was okay,
or their car.
Which
not driving,
again,
of course.
If it was an accident, if it was a trauma related to driving, maybe not. But again, the devil's in the details, and making sure that you're talking.
Preparation is everything.
Yeah,
for sure. And so we can tell people about our little form that they can download online, because we, through working in the pandemic and getting people who really weren't prepared to do telehealth, ready to do telehealth. I mean, if you think about it, when you walk into your therapist's office, there are cues that tell you how to behave. And you're supposed to pay attention to the person in front of you, and you sit in a chair, and you don't multitask, and you don't check your email while you're doing therapy, and you don't, there are lots of other things. The other thing is you have a little time in the waiting room before you go in to kind of think about what you're going to talk about. And then you have some time when you leave the session before you get home to kind of decompress and re-enter your life again. You don't have any of that in telehealth. And people don't know to make that time. People don't naturally just kind of figure out how to do that. So we created a form, and we added to it over the entire pandemic to just things that we had run into. So to let the clients know what they needed to do, how they needed to treat their telehealth session, and how to take some time before and after to kind of put themselves together. And so you can find that on our website. Can we put links in
the show notes
next to in the show notes or something near the podcast, so that people can see the links to that? I think a lot of our therapists have found that really helpful. And having it in a form helps you, not forget what to tell the client, but it also gives the client a sense of the formality of therapy. That, we've had some crazy stories. We've had people consult with us and tell us that they were doing, they could hear a noise in the background. They asked their client what it was. They were going through the drive-through at a fast food restaurant.
Right.
We've had people, that you can kind of tell they're clicking to another app on their computer while they're talking to you, checking their email. I mean, you wouldn't do that in the office. You wouldn't even have access to that in the office. And so people really have in these days gotten used to, if they have their computer open, they're multitasking, they're having all kinds of things going, and you become part of that environment. I think it's worthwhile telling the client that we don't do that in therapy, and helping them understand that this is really precious time, and it needs to be really focused on the goals at hand. And it helps them do that when they have a little bit of preparation.
I appreciate that a lot, because I think we don't it becomes so second nature to us when we're meeting face to face that we don't think about that necessarily when we're making that transition, but it becomes a really important piece for seeing anybody. And I like too the idea that, this does work. Like, we can do this. And while it will look a little bit different, and while we may do things slightly differently, whether that's, for the session practically itself or for in vivo exposure homework or whatever it may be, that people can really still take advantage of these principles and get the benefits of doing therapy. And I mean, in many ways, it gives us as therapists like a new opportunity to develop some new muscles too, and kind of think about how are we adjusting to the real time demands that are going on in front of us. It's kind of cool that we have to think about how we might do things differently in an effective way too. I think
all of us have tried to relay that message to the folks we consult with. Like, let's not see this as a problem. Let's see it as an opportunity to, really do it. Some of it's uncharted territory for sure.
Yeah.
And, we're going to get a lot of information out of this, but I think seeing it as an opportunity, and what's the alternative, right? Like, if we don't do this, what's the alternative? So it can work. I think work. All of us want to reinforce for all you out there, consultation can be key. Don't struggle alone. Don't try to muddle through this.
Yeah.
So hopefully you've got colleagues you can consult with, and certainly, we have great consultation here that all of us are really passionate about. So we will definitely put some links in the show notes. But I do want to thank you so much, Kelly, for taking the time to chat with us today. If you had one actionable intel, so we try to leave our listeners with like an actionable intel, an item, a thing they can do that can sort of change their practice tomorrow, what would be one thing a provider could do, or our listeners could do to help move them forward with this?
If I had to give one takeaway, I would say trust the treatment. Trust the treatment. This treatment has been tested in many, many different places with many different kinds of people, many different kinds of therapists, and it works. And it works over telehealth. We have lots of data to show that. And so I would say trust the treatment, and I would say use the tools that you have. And we have lots of tools for you on our website to help you make adaptations when you need to. But the treatment is a robust treatment. It can stand up to the pandemic. Mm-hmm. And we have seen people do some great work over telehealth who were not prepared to do
Phenomenal
work. And we have seen people actually benefit from telehealth in unexpected ways, because accessibility is an issue for many people, and being able to get your therapy on your computer screen instead of having to travel to it is a gift for some people. And therapists have been reluctant to provide that because they have all these concerns about it. But when they were forced to do it by the pandemic, turns out their clients really benefited. And I think people have at least appreciated that this is a new way we can help people. And, we're not so rich in ways to help people that we can turn any of them down. So I think being able to reach people on telehealth is really something everyone should really try to add.
There's no going back now.
There's no going back. And we've also heard anecdotes from people where telehealth really was a bad choice for a client. It wasn't the best modality for them. And that's going to be true for people as well. And even for therapists, there are some therapists who just can't get comfortable in telehealth. And I think that's reasonable. And in that case, you should not do it. You should do face-to-face therapy, and the patient, if at all possible. Yeah, the patient should get face-to-face therapy as well. But if there is no alternative, then this is not a second best choice. Telehealth is a real and viable option for people, and it can work as well as face-to-face therapy.
I think of it really as we've all as therapists been forced to go through the same process we ask our clients to go through, right? We were avoiding this thing called telehealth for a long time because we had all these really bad anticipated outcomes that were going to happen if we did it. Now we've been forced into that situation to confront it and to do it and to try it out. And it turns out many of those anticipated bad outcomes that we worried about aren't happening, and people are getting better, and we're adjusting our expectations. So
Absolutely.
All right. Well, thank you so much again, Kelly. We will definitely be having you back multiple times and always value your experience and insights. And thanks for all you do.
Thanks for inviting me.
Thanks for listening to Practical for Your Practice.
Please feel free to subscribe, rate, and join in on the conversation in the comments.
Until next time.